Good day after. Welcome to our noon keynote speech. My name's Bill Hoagland. I'm a new member of NASI. I've spent my entire public career in this town dealing with the federal budget. A couple of years ago, I retired from federal service and was employed by a health insurance health service company. I guess I didn't realize what I was getting myself into. If I thought balancing the federal budget was tough and a challenge, health care reform has been even more challenging. Of course, the two are not, they are inextricably linked. So it's with great pleasure and honor that I have here this afternoon the duty of introducing the distinguished keynote speaker, Secretary Sebelius, to talk about health care reform and its implementation. This is a return visit for the Secretary. She was before NASI a few years ago as a state insurance commissioner for Kansas. Of course, she later moved on to take the position of governor of the Sunflower State. Secretary Sebelius has been a leader in health care, family, seniors issues for over 20 years. Today, she's, of course, the highest-ranking health official. Secretary Sebelius is guiding the implementation of the historic Patient Protection Affordable Care Act. She's also at the forefront of the administration's efforts to build a 21st century healthcare system, from putting a new focus on prevention and wellness to promoting electronic health records to expanding primary care workforce. I know at least secondhand from my marathon running CEO that she practices what she preaches on wellness. A regular jogger, runner. Herself, my CEO has unexpectedly crossed paths with her in a very positive way in the early morning hours on the mall. Following the Secretary's remarks, she has graciously agreed to take a few questions, but she does have a very hard stop at 12:30. So, Madam Secretary, it's a real honor, and thank you for spending time with us.
Well, good afternoon, everybody. I think those of you who live in Washington are lucky to be in a windowless room because it is snowing again outside, and at least in my office they're having a little post-traumatic stress syndrome based on the other night's commute, but it isn't sticking, it's just nice flurries. But it's great to have a chance to be with you, and thank you, Bill, for that nice introduction. I do see David Cordani on the mall periodically, and it's become a good time for him to come up alongside and get a few key points in, and then he runs a lot faster than I do. I said to people, I still am running, but now people are chasing me, so it's a slightly different sensation. But it is great to be back, and great to have a chance to join you at this historic moment and have an important conversation about changes in the healthcare field. I know that for really a quarter of a century, the National Academy of Social Insurance has really led the way in arguing that a strong social insurance system contributes to a more prosperous future for all Americans, and that is certainly a viewpoint that I share and have worked on along with you along the way. I think it's an even more important message today as we continue to recover from what's been the worst economic crisis, certainly in my lifetime. And what we've seen in the recession that began at the end of 2007 is really a crumbling of the fabric of life for a lot of Americans, when people lost their jobs and lost their houses, which often were their most valuable asset, lost their health insurance along with their jobs, saw their retirement accounts dwindle or disappear altogether, and whatever savings they may have set aside also was drained to try and provide their own safety nets. And what we know is that, unfortunately, we're still in what amounts to a pretty jobless recovery, that while we've added jobs for the last 12 months, we still have way, way too many people who still are in those recession conditions. And so at a time when we've looked at the you know, the private sector economy kind of crumbling around people, what we are more aware of is how important the social insurance programs are, that the recession would have been incredibly worse for these families, the downturn much deeper, and our recovery far slower without that fabric of safety net programs. Literally tens of millions of Americans have been kept out of poverty because of the programs. More people have become qualified. And by strategically bolstering those programs, which is what a third of the Recovery Act money really did, go into countercyclical efforts, we think about 4.5 million people were kept from falling below the poverty line because of that network. So those families at least could continue to pay bills and meet mortgage payments, and in turn injected additional money into the economy, which again stabilized some of those situations. The recession, though, I think also highlighted shortcomings, particularly as it relates to the health network. We have the highest number of people now recorded without health insurance, 50 million Americans, since they began keeping statistics. We know that folks have been lost their insurance because of job loss, have no health coverage often because they don't have the wherewithal to pay for it, or just been priced out of the marketplace. And that comes with it a huge toll. We know that individuals without insurance are more likely to skip the kind of preventive services that find health situations at an earlier place. They don't get prescription coverage that often keeps them on some stable pathway. And if they do end up going sick, often go without the early treatments. But those costs actually go far deeper than just the missed health opportunities. What we know is that in a condition where you're not healthy, students miss school and workers miss work. When they do get care, those costs are more extensive and expensive, and they get passed along. And on average, about $1,000 a year more is paid by those folks who are insured to compensate for the costs of those who have no coverage and still access services. So without counting the cost to the economy of the countless Americans who decide that they can't switch a job or they can't start a business because they're job locked with health coverage, there are huge costs along the way. And closing that gap is what Senator Kennedy used to call the great unfinished business of our society. Now, unfortunately, he didn't live to see the passage of the Affordable Care Act, but it certainly was a piece of legislation that he had championed and worked on. In fact, I still feel honored by the fact that the last hearing that Senator Kennedy chaired was my confirmation hearing, where he came and sat in the chair of the HELP committee and was there the whole time. The Affordable Care Act really is beginning to change that scenario, and we think it's a good measure of additional freedom for a lot of Americans. First of all, it begins to change the rules about those with pre-existing health conditions. And when we talk about pre-existing conditions, we often think about somebody who has a visible disability or a congenital illness. But in the report that our department put out recently, in the population, there are about 129 million Americans with a pre-existing health condition that actually changes their insurance status, that are taken into account when insurers look at the population. That's almost half of our population are in a category, so it's not somebody else, it's really all of us. And that same report found that about 30% of the people under 65 who are perfectly healthy today will in the next 8 years develop some kind of pre-existing health condition. Again, a category of folks that is a lot of Americans. And it's not uncommon for those folks to actually have an enormous difficulty getting insurance coverage. Between 2007 and 2009, the nation's 4 largest for-profit insurers denied 1 out of every 7 applications because of a pre-existing health condition. Didn't just rate them up, but said, you know, you are not going to be covered. And that's beginning to change. Children, as you know, this year can't any longer be denied coverage because of their health status. And in 2014, the pre-existing condition limitations will be outlawed for good for everyone. And so we'll no longer have children whose parents are worried day in and day out because they can't find the health insurance needed, and we won't see budding entrepreneurs or small business owners who can't get health coverage because they're a breast cancer survivor or they have a condition. The next step is really to make sure that folks have the treatments and medicines that they need. And unfortunately, the practice of rescissions was still alive and well, where people were dumped out of an insurance market, even though they had paid premiums on a regular basis because of some technical problem with their application or with their form. It wasn't a universal practice, but it was a documented practice that has come to light, and that rescission practice is now against the law. People are also beginning to see some opportunity to look at premium increases. I'm a former insurance commissioner, so this is an area I know pretty well, but I know that those of you in the room who are part of insurance companies have often been in a marketplace that's opaque even to you. What other companies are selling at what price to whom has been very difficult to get a handle on, and it's almost impossible for an individual who is trying to shop in the marketplace to figure out what is the marketplace, or a small business owner who doesn't have a large HR department to navigate. So some of the issues that have now come into the forefront about transparency are not only helpful to consumers, but I would suggest helpful to companies who have often operated in a pretty opaque system. We're pursuing a range of reforms to look at increasing premiums. And as you know, a lot of these early advances are really aimed at a portion of the marketplace that has been pretty unstable for a long period of time. Individuals purchasing coverage on their own, and there are very few insurance laws that often wrap around that group of individuals, and small business owners, which often did not have the same kind of market protections and certainly didn't have the same kind of market leverage that large employers had. And that's really been the focus of a lot of these changes. The big change in the market side will come in 2014 when the exchanges will be created in every state. State-run exchanges, private insurance companies competing in a pooled operation, so that folks who have often been navigating on their own will have an automatic pool and will have an opportunity, again, without pre-existing condition limitations, to purchase coverage. So those changes are underway. Now, there are lots of disputes about cost savings and not cost savings, and as Bill told you, his expertise is in the budget offices, and he's a former administration official. We have relied pretty consistently on the Congressional Budget Office as a nonpartisan broker. We certainly don't agree with every one of their numbers, but have relied on those numbers as a consistent source of information. CBO estimates that small business owners are going to save about 20% on their health insurance bills once the exchanges are up and running. And that's before you look at new tax credits which may be available. So a family of 4 earning about $55,000 a year could save on today's rate, about $6,000, making insurance actually affordable for the first time for that family. If you have a lower income, that tax credit is even higher. And the new law strengthens Medicaid and CHIP, two programs that already are playing an incredibly important role. And as you all know, Medicaid numbers are now increased based on the downturn in the recession. When the reform, I think, fully takes effect, we'll be able to say for the first time that all Americans have access to affordable health insurance. The best estimates are that we'll see about 32 million Americans come into the marketplace, but we don't know that that's really the end of the story. I think those numbers change. It will, I think, have an impact on our workforce. It will free people from some of the situations that cause job lock along with insurance coverage and make the market, I think, more flexible and more competitive. The social insurance system, though, is only as strong as it is sustainable. And I think what you're seeing is a discussion today where people say, you know, this law, which was passed 10 months ago, is the direct cause of rising healthcare costs. And I would just suggest that anyone who looks at what has happened with the trend lines over the last decade, 2 decades, 3 decades, understands that the underlying health costs have far exceeded inflation year after year after year. I know it's something that insurers, employers, government officials have struggled with for some time. And again, I think we have an enormous opportunity with the framework in the Affordable Care Act to make a big difference. In the past, Medicare and Medicaid have been volume purchasers, not value purchasers. And we have been having some important conversations with executives across the country who really are very anxious for us to use the public system, the payment levers in the public system, as an incentive to change the delivery system. And for the first time, the Affordable Care Act really gives us the framework to be able to do that. The current estimate, and this really comes out of the provider community, is that about 30% of our current health care spending, about $700 billion a year, is for services that really do nothing to improve anyone's health. So we are paying an extraordinary amount of money for goods and services, equipment, devices, whatever, that really do not add to the benefit of the people we are trying to serve. And that means there's a lot of work to do. Medicare, for instance, just recently stopped paying for never events. Those are what happens to you when you go to the hospital and, in a graphic example, somebody amputates the wrong leg. Unfortunately, it does happen, or performs the wrong surgery on the wrong patient, or delivers the wrong drug. In the past, up until just 12 months ago, Medicare paid for that procedure because it was a procedure. That is no longer the case. Medicare, for instance, did not cover, in another example, smoking cessation assistance for beneficiaries until they presented with lung disease or cancer. And then you would actually have assistance to stop smoking. We think it makes a little more sense to actually assist people stopping smoking before they present with those diseases. So those are the kinds of initial changes that are beginning. But much more important, I think, will be the changes that we can collaborate and work on together, which are aimed at improving overall care for every American, not just those who are Medicare and Medicaid beneficiaries. But since Medicare touches every hospital, deals with most doctors, most drug companies, most device companies, the changes that we can actually help to drive will accelerate care improvements across the country. We know that better care at lower costs is available and is a goal that is achievable because it exists in pockets of places. What we don't have is that kind of care taken to scale. And I know that this is an area that will be an enormous focus going forward. We know, for instance, that 1 out of 5 Medicare patients who leaves the hospital is readmitted within 30 days. And most of those patients have never seen a healthcare provider in the intervening time. And I don't mean never seen a doctor, never had a follow-up call from a nurse or a home health worker, never checked to see if prescriptions had been filled or if the treatment was going right. And we know that intervention in that 30 days can lower those readmission numbers by 2/3, because that's what's going on in parts of the country where they actually have coordinated follow-up care. That's an enormous cost saver. It's also a lot better for the patients, because no one I know likes to come out of the hospital only to turn around and go right back in. We know that hospital-based infections can be dramatically lowered, again, because some systems have done that. Not with fancy new equipment, not with a lot of money being spent, but with a leadership and regimen protocol that is reinforced at every step along the way. And we currently have about 100,000 people die every year from the hospital-acquired infections, and close to 500,000 people who every year extend greatly their hospital stays because of hospital-acquired infections. So just getting at those two targets can make a significant difference, not only improving patient care, but actually dramatically lowering some of those costs. We're also launching, for the first time, I would say ever, a really unprecedented look at fraudulent activity in our public programs. Now, Medicare last year expended about $415 billion. We move more than $1 billion a day, if you will, on average in goods and services and equipment. That is a very prime target for fraudulent activity. And frankly, it's been way too easy. It's been way too easy to hang out a shingle and begin billing the program. It's been way too easy to try and create a fraudulent service, and those days are really over. The President charged the Attorney General and me to come together and really put together a coordinated effort that's everything from, now we have 7 strike forces in cities around the country are the real hot spots of fraudulent activity, to changes in the law which make it much tougher, frankly, to be a provider in the first place, require considerable more background checks and activity, but allow us to build a system very similar to the systems used by credit card companies. You know, when somebody tries to charge 12 flat screen TVs to your Visa card, you get a call saying, this is kind of an odd billing. Did you really buy 12 flat screen TVs? So they stop the charge to your card before it's ever made. We don't have that capability currently in the federal government. We're on a pay and chase program, so the money goes out the door, and then after the fact, we try and track down who indeed did this activity. The Affordable Care Act changes that and gives us new penalties and new opportunities. So we are really not only in the Affordable Care Act looking at the insurance side of the marketplace, but I think the even bigger story is the delivery system pieces of the healthcare system. And again, with your help and support, I think we can continue forward. So I'll stop there. I know that we're close on time, and I apologize. This is a complicated law and a lot going on. But yes, sir.
Thank you, Secretary, for joining us today. I'm curious your thoughts about next steps if the courts come out and rule against the individual mandate. What are some of the other mechanisms that you think would be reasonable as replacements?
Well, frankly, I don't know that we're currently exploring other mechanisms. We feel that it's on solid constitutional grounds. There are 2 judges that have ruled that the mandate is constitutional, one who has ruled the other way. We're waiting for the Florida decision. It's going to be a while before this wends its way through the courts, but at least our legal team feels that this is on solid constitutional grounds and that it clearly is the most effective mechanism to get everybody in the pool. There probably are some backup strategies, but at this point, We're just pursuing the court case and working with states around the country. I mean, the interesting thing is most of the states suing us are also setting up exchanges. So we have a sort of implementation strategy that's continuing. Yes, sir. Okay.
Sure, yeah, kind of a follow-up to that. I mean, you mentioned that 27 states have filed suit against the individual mandate. I just wanted to ask, I mean, are they all wrong? And where in the Constitution does Congress get the authority to mandate that Americans purchase a product like health insurance? That seems to be the central question.
Well, I think that let me begin by saying I'm not a lawyer, and I'm leaving those arguments to our legal team from the Department of Justice. But I think there are certainly lots of talented constitutional lawyers who feel that the Commerce Clause very much is broad enough to cover the interstate commerce of healthcare, and that we have a unique product because people access services of healthcare whether or not they have insurance. What they're choosing not to do is actually pay for those services. So it isn't like if I don't have a 27-inch TV for the Super Bowl, I can't demand the day of the Super Bowl that somebody deliver that TV because I have a right to it. On the other hand, if I don't have insurance, I come through the door of an emergency room and get treated and get cared for, and somebody else picks up that tab. And I think it's that framework for a layperson that the two judges that have ruled that this law is constitutional find to be well within the scope of the Commerce Clause. Keep up your good work. Look forward to working with you. Thanks so much.
Sorry, I should have answered more questions.
Thank you very much.